Well, good afternoon, everyone, and welcome to the Health Equity Jam session today, November 17th, I believe it is. We're happy to have you all here today, and we're looking forward to today's session, which is going to be on the topic, Can New Mobility Be a Win for Health Equity?, which is going to be presented by Bloomberg School of Public Health faculty members Johnathon Ehsani, who is Assistant Professor, Department of Health Policy and Management, and Jeff Michael, who is a Distinguished Scholar in the Department of Health Policy and Management. But before we move into our talk for today, we always start out with fun facts. So we're going to learn a little bit more about each of our speakers. We'll tell you more about their professional work first, and then we'll learn about their fun facts. So Johnathon Ehsani has been working in the area of public health road safety for almost 2 decades. He conducts policy and behavioral research to prevent motor vehicle crashes and advance the health promoting aspects of transportation. And Jeff Michael has worked in road safety for over 30 years, including the highest levels of government service at the National Highway Traffic Safety Administration. He joined the faculty at Johns Hopkins 3 years ago and is coordinating the New Mobility Initiative. This initiative is an effort to provide evidence-based policy to steer the deployment of new mobility products and services for public health benefit. So those were their formal introductions, but now we're going to give you their health equity introductions. So first, I always like to engage the audience in this because we have so many smart people in the audience that sometimes they can figure out everything about our speakers, things that I didn't even know. So let's take a guess. Where was Dr. Ehsani born? Let's see if we can get some answers in the chat. Where do you think Dr. Ehsani was born? Want a fun fact about Dr. Ehsani. And while you're doing that, let's see. You probably want to hear, you can also think about the music we heard and start thinking about what that was and take a guess at whose favorite music that was. Was it Dr. Ehsani's favorite music or Dr. Michael's favorite music? Okay, so we've got in the US, we've got Australia, we've got the US, Egypt, Turkey, or Iran. We've got 2 Irans on here. So let's see, lots of different ideas here. I think some people Googled Dr. Ehsani's name. But no, anyway, Dr. Ehsani, yes, was born in Iran. So people are even admitting that they Googled it. No Googling for fun fact answers, please. Dr. Ehsani was born in Iran, but somebody else was pretty close because he left there due to religious persecution when he was a child, and then ended up growing up in Australia. So whoever said Australia was probably, thinking about, maybe they heard Dr. Ehsani's accent or something and came up with that. All right, well, whose favorite music were we listening to and what was it? Anybody want to take a guess at who the artists were, what the song was, and whose favorite music was it? So yeah, Luis Quintero says the music really sort of made him think that Dr. Ehsani might be from Australia. Okay, well, we got, how many different answers do we have here? Oh, we said, well, some people thought that might be Dr. Michael's favorite song. So I think, Luis, I think you are the winner for this one. The group is Midnight Oil, and the song was Beds Are Burning, right? It was nice. I liked it. Had a nice feel to it. All right, well, we're going to go on, and we have one more guest. I'm going to give you 2 fun facts, and you have to tell me which speaker is connected to which fun fact? So one of these speakers is a mechanic who restores classic cars and motorcycles. Let's see whether you can guess who that is. Nice hobby, somebody says.
Well,
Some guesses. We've got 2 Dr. Michaels on there. Anybody else? Any other guesses? Oh, well, that was, you guys called that one. Everybody said Dr. Michael is a mechanic who restores classic cars and motorcycles. We have a speaker who plays cricket and rugby. Who might that be? I think you guys probably got cheated a little bit from the earlier questions, but you never know. I mean, things don't always like go the way you think they're going to, right? So there is a speaker who grew up playing cricket and rugby. Everyone's saying Dr. Ehsani. Okay, you got that right. We got one more fun fact related to music. Which one of these speakers actually plays a musical instrument? And after that, then you also have to guess not only who plays it, but what do they play? So let's have some guesses about who plays a musical instrument and what musical instrument. Dr. Michael, do you play the guitar? Dr. Ehsani,
no.
You're a violinist? Another violin guess for Dr. Ehsani. Flute. Okay, well, let's see. You can unmute yourself if you'd like and share whatever instrument each of you plays. Or I know the answer to one of them, and I haven't seen the right answer so far, but there could be an answer that I just don't know that might be right on here. So Dr. Michael.
Well, those are good guesses, and and I do play a stringed instrument, but it has fewer and larger strings, and so it's a bass fiddle. And I played in that opening track, actually. Not really.
That's a good one. You said that with a straight face, though.
Yeah.
Okay.
I played in a band called the Broken Down Ramblers. And we played the county fair and retirement village circuit.
Wow. Okay. Sounds like fun, though. Sounds like a lot of fun.
It's not very demanding.
So what about you, Dr. Ehsani? Do you play any musical instruments? And then also tell us, what position did you play when you played rugby?
Happy to. Yeah, I do play, actually. I do play a little bit of guitar and a little bit of violin. So there were some great guesses there. Terrific. And in my younger days, I played as a forward in rugby, which is kind of a scary position to play. And I played, if people are familiar with rugby, I played that position in the scrum, which is right in the middle, called the hooker. So my job was to kind of collect the ball with my feet when they fed it into a scrum. So for those of you familiar with rugby, it's a highly injury-prone position, which then explains my later career into injury prevention.
Oh, wonderful. Thank you for sharing those fun facts with us. Well, without further ado, I give you Drs. Ehsani and Michael, and we look forward to hearing their talk today.
Well, I'll start off, and very nice to be invited to speak with you all today, and hope what we have to say is interesting. Let me just go ahead and share my screen here. Jonathan, is that okay?
The other thing I didn't do actually is to say who I was. So for those of you who don't know me, I'm Dr. Lisa Cooper. I'm the director of the Center for Health Equity, and it's my pleasure to welcome you today to the Health Equity Jam session.
And Thank you, Lisa. And Jonathan, would you like to say hello while I share my screen?
Yeah, terrific. Yeah, really, it's a pleasure to be here. And the way we, I suppose I can mention, we're very grateful to the Center for Health Equity and the Urban Health Institute, which are supporting some of our research in new mobility and health. So it's through that connection that we find ourselves here. I know many of you are interested in issues of health equity, and some of you may have also interest in social determinants of health also. So this is kind of thinking very broadly about transportation as a social determinant of health. So that's kind of the premise of our work. And Jeff and I have a few slides to share with you and really a lot of questions for you today. Over to you, Jeff.
Thank you, Jonathan. I think we come to you sort of humbly today with the title of our presentations in the form of a question, and we're serious about that. We're sort of pursuing hypotheses with regard to new mobility, and we'll explain what that is. But we think that they are relevant to safety and health and equity, and we'd love to get your feedback on that, because I think both Jonathan and I are strong in the safety area, that our backgrounds are not as strong in the equity area, and so we'd love to have some input from you on that. So if I can get my slide to advance here, we go. So I'm going to start off from our area of strength, which is the safety area, and just give you a little bit of background. So I used to be an auto mechanic, as I mentioned, and that sort of pointed me towards a transportation career. And I worked in road safety for a long time in the government, and now doing road safety research at Hopkins. And so I can give you a kind of a lifetime perspective of road safety history. And in short, it's not a very positive one. It is prior to the pandemic, motor vehicle crashes were the leading cause of death for young people in the US and around the world, up to, for most age years up to age 29 or 30, leading cause of death persistently for decades. And the critical behavioral correlates of traffic safety didn't change much during my exposure to the field, which started in the 1980s. We made some improvements in drinking and driving, which is one of the major correlates, but that improvement really stopped in the 1990s, and we've been kind of flatlining since then. Seatbelt use has increased rapidly through the 1990s, but then began to level off, and we're up at the 90% level now, but it hasn't changed much over the past 6 or 8 years. Speeding has remained relatively flat for a long time. Speeds have gone up as states have increased speed limits, but speeding, exceeding the speed limit, has remained fairly stable. So, from my perspective, sort of the summary is that we've made about as much headway as we can make in adapting people to a system which is, I believe, is sort of fundamentally unsafe. And I'm glad to be working sort of on the other side now, which is, trying to improve the safety of system to serve people. So that's an important distinction, and we'll sort of get into that a little bit later. But making this change from having a fundamentally unsafe system, which requires adaptation by people, to having a fundamentally safe system in which people can be safe. That's a big change from where we are. And I feel like we're at the beginning of that change now. We're gaining momentum on that change, and leadership is needed. And governments have a role. As a longtime government person, I see governments certainly have a role in this, but the role of government has diminished over the past decades, and they're not as powerful as they once were in this area. There's a leadership gap that I think public health can fill, and specifically Johns Hopkins, of course, and that is largely because mobility is related to health, and in several dimensions, not only safety but also well-being and access to determinants of health. And of course, it needs to be, this safe mobility needs to be available on an equitable basis. If a recent report by the Governor's Highway Safety Association sort of documents the interaction of different parts of our population with our mobility system, and you can see that there's quite a discrepancy across parts of our population. These are obviously complex interactions between these segments of our population and, in this case, our road system. But if you believe that our transportation system, the one that we built to serve us, should in fact serve the population, then the discrepancies you see here is an indication of serious problems. If that was overall traffic deaths, and if you look more closely at pedestrian traffic deaths, it begins to sort of tell a story. Pedestrian fatalities are, of course, tend towards urban areas where the highest risk is, and that association with urban areas sort of tilts it towards certain parts of the population. And if you notice, if we go back, if you notice, for example, the Hispanic bar there, in overall traffic deaths, the Hispanics are slightly below the total population in fatality rate, and pedestrian, they're slightly higher, and that's just one indication of the inbuilt bias we have in our current mobility system. So that the bad news, I think, with regard to our current status is that we have a large and persistent problem, and that it's made yet worse by an unequal burden on parts of our population. But we have a bit of promise, and that's what Johnathon and I are working on. We have in front of us in coming years emerging mobility developments that are going to be far-reaching, and some of them are technologies and others are methods, and their impact on our society is yet to be seen, but it is very controllable. And we think that with some intervention from Johns Hopkins School of Public Health, that we might be able to contribute to that control. So we're going to tell you a bit about our work, and then hope to get some of your views. So I'll turn it over to Johnathon now to kind of walk through some of our what we're working on.
Thank you, Jeff. Let's now talk a little bit about kind of the premise of our work and the idea of new mobility. So unlike the existing kind of, if you like, actors in our transportation system, new mobility are new inputs that are coming in. You'll be familiar with some of these, but they're all relatively new. They've all emerged probably in the last 5 or 10 years. And the advantage is that they're increasing rapidly, and they're highly efficient. Their efficiency is partly empowered by artificial intelligence and kind of technology developments. But their efficiency is also partly from public policy, because they're new. Because they're kind of new inputs into the transportation system, we could control them. When a company approaches the city of Baltimore and says, hey, I want to deploy 1,000 scooters, they need to ask permission. And for that reason, the city of Baltimore could then kind of add additional requirements for that permission. And some of these requirements could be those that increase access to transportation. And for that reason, we think new mobility could be a win for health equity. Thanks, Jeff. Next slide, please. So rideshare is probably the mode that you're most familiar with. Rideshare is a type of taxi service, for lack of a better word, that allows people to ride in a vehicle, either alone or with others, and they hail it on their smartphone. Now, obviously, the pandemic made a big dent in ride sharing. It was down up to as much as 80% when in the early days of the pandemic, but the numbers are rebounding now and approaching pre-pandemic levels. Some people have decided to opt out of owning vehicles because in some cities, ride sharing is quick, it's reliable, it's clean, and it's affordable. And as many of the ride sharing companies, you may know this, that many of the ride sharing companies also have kind of interests or their own driverless car divisions within them. So they see their profitability and ultimately their survival on eliminating drivers, basically, and making therefore the cost of the trips very low and fully electric. And so the cost of the trips is projected to drop sharply. Again, that's a hypothesis that they're testing, but that's one that is kind of in motion with a great deal of investment behind it. Before the pandemic, Uber was reporting up to 14 million trips per day, which increased taxis in New York City. And in New York City, again, a highly urban environment, and probably that's where the majority of ride sharing is occurring in this country. Uber and Lyft are giving more rides every day than taxis. In the second quarter of this year, they gave 1.5 billion rides in the US, and that's only down by 10% from pre-pandemic levels. So yes, the pandemic put a dent in ride sharing, particularly during 2020, but this year it's come racing back. Please continue, Jeff. So the another example of new mobility is pedal bikes and e-bikes that you may have seen deployed in urban areas across the country. These are again kind of rentable, and they're shareable. They're accessible via a smartphone application, and they come in various forms. You can find them kind of attached to a dock where you have to go to a kind of a particular station and dislodge them and take them away, or they're kind of dockless, which means that people can ride them and leave them on the sidewalk, and another person can come along and rent them. Now, NACTO, the National Association for City Transportation Officials, reported a total of 136 million trips in the US in 2019. Of kind of shared bikes and shared scooters, which I'll talk about in a minute. And 2/3 of those were actually scooters, and 1/3 were bikes. Now, these often are for shorter distances than ride sharing, and I think they're intriguing from a public health perspective because they include kind of physical activity. They might enable access to places that people wouldn't be willing to walk to, but close enough that they wouldn't want to drive or take a ride sharing, and they're reasonably affordable. So you see a lot of young people using these now. Where I think the other side of this coin is, which is another area of our focus, is that often the infrastructure is lacking to use these dockless vehicles safely. So you often find yourself, if you've ever used one of these, on the sidewalk or braving traffic. Often, and young people who are using these, or anyone really, may or may not be using helmets. So I think there's a complex input to the new mobility environment. But in the next slide, Jeff is going to show you is oh, no problem. Is about scooters. Now scooters are really intriguing because I think again they represent the vast majority of kind of these dockless vehicle rides in the country, and scooters are by their very nature kind of dockless, and they're electric, so they're clean. They allow people to get around, and if we go to the next slide, I think we'll see that one of the challenges with scooters is that they can often clutter the sidewalk. I've personally tripped over a few in my time, and cities are beginning to kind of crack down on where they can be parked and establish kind of areas in a sidewalk where it's okay to park these, and establish rules and regulations. For example, in Washington, D.C., every scooter now has to be locked to a fixed place so they're not falling over and getting in the way. But again, they're highly popular, and the number of scooter trips doubled between 2018 and 2019, reaching about 80 million trips in 2019. And this was actually the origin of our beginning of our collaboration with some colleagues on this call, which is a project that we're currently doing with the city of Baltimore. So Baltimore City has a dockless vehicle mobility program. And in Baltimore City, like many cities, actually, their dockless vehicle scooter program is very popular. Prior to the pandemic, it was remarkably successful. The peak levels dropped by about 2/3 in 2020 as a result of the pandemic, but they've gained back, and they're still about 1/3 below what they were, but they're coming roaring back. And I think it was in this context that the city of Baltimore actually reached out to us and said they were interested in evaluating a very specific policy that they have in this city, which is called an equity zone policy. Now, an equity zone policy is a geographic equity zone policy. They also have a kind of an equitable access, meaning a kind of a low-cost ridership program. But in this particular case, Meg Young, who is the city official who directs the dockless vehicle program, kind of mandated through the use of data, basically, that scooter companies, in order to operate in Baltimore City, distribute their scooters across the city, not only in the areas where they're going to make the most money, which is like in the dense urban core, but across about a dozen equity zones, which she identified through kind of geospatial mapping and census data and so on, that were kind of mobility deserts. These were places where households had very low access to vehicles. They had poor, they were far away from public transit, and so people living in these neighborhoods really were without easy transportation. So every day at 6 a.m., every single scooter company needs to have at least 6 scooters in these equity zones across the city. And through the help of a grant from our colleagues, we've helped the city of Baltimore execute an evaluation of these equity zones using an incredible partnership that we thought would never actually kind of have been possible until we tried. But it actually involves the use of us circulating a survey to scooter users who are originating their trips in an equity zone through the survey companies. So Johns Hopkins deploys a survey through the apps of Lime, Spin, and another company called Link. And every time a scooter user initiates a trip from one of these zones and finishes their trip safely, they get a little ping. And that ping says, please complete this survey from Johns Hopkins. And that's what this work that's kind of the origin of this work. And again, we're still in the process of learning about the use of equity zones and evaluating their impact. But that's what this that's one of our kind of experiments, if you like, to examine the effect of new mobility. The final example I'm going to share with you is about autonomous vehicles. Yes, this project was funded by the by the Urban Health Institute. Yes, thank you. Sorry, I'm just catching those questions in the chat there. The final example of new mobility is autonomous vehicles. These are, until recently, the realm of science fiction, and still a ways away for most of us to really experience them. But there's about 1,500 of these vehicles being tested or actually deployed in the United States. Currently, in the Department of Health Policy and Management, our distinguished policy scholar, his name is Mark Rosekind. He's a former NHTSA administrator, but he's also their Chief Safety and Innovation Technology Officer at a company called Zoox. And this is an example of their vehicle, and they're currently testing in both Silicon Valley and in Seattle. Waymo, or Google, as some of you may know, has active autonomous vehicle deployments in both San Francisco and in Arizona. And right now, people in San Francisco can ride in an autonomous vehicle that is operational and allowed by the state of California. So again, they're just really at the very beginning, but this is actually the reason why we think it's important for us to be right here at the ground floor. While these are being tested, developed, and deployed, our premise or our hypothesis is that public health has a unique contribution to make, and our contribution is safety and equity. We want to make sure that these new mobility technologies and services are safe, first and foremost, but secondly, we want to use public policy to make sure they address existing, well-established and kind of, historically, entrenched disparities in access to transportation, which we think, again, will be one contribution towards addressing those disparities. Certainly, there's a lot of work that needs to be done to address disparities in transportation access, but this could be one step in the right direction towards that. Over to you, Jeff.
Thank you, Jonathan. Further on the topic of automated vehicles, and particularly automated vehicle shuttles, which may be the form of automated vehicle that might be most relevant to concerns about health equity. So we've had a positive development this week, Jonathan and I. We got an award from the State Department of Transportation, Maryland State, which is the first one we've gotten from them, which was terrific for us. It's for the development of equity metrics for what they call connected and automated vehicles in the state of Maryland. And Maryland has been quite proactive in planning for automated vehicles. And, there's a lot of implications of adopting driverless vehicles, in the state vehicle fleet. And one of those, frankly, is economic. And this is a big industry. There's a lot of money, billions of dollars, being put into the development of automated vehicles. And the firms doing that development are locating around the country, in some cases nearest where there are good places to test the vehicles. So Maryland and other states are trying to position themselves to be good places to test automated vehicles, because it can attract that, part of that industry and the economic development that goes along with that. Well, part of their planning is to sort of think forward about the applications for automated vehicles, and they, like us, are thinking that they could be relevant for equity, and they've asked us to develop sort of a rationale for planning how to do this. So we will be developing metrics for them to, number one, identify areas in the state that might benefit from, for example, an automated vehicle shuttle service, and then to do some community outreach in those communities and talk to people about if that were to happen, how they would like it to happen and how it would best serve them. And then do some modeling and some simulation of how that could work and estimate what the potential benefits could be. So now the theory behind this is that automated vehicles, on the one hand, they're not dissimilar to conventional vehicles. I mean, that Zoox shuttle looks, approximately like a conventional passenger shuttle that you might ride from the airport to the parking lot in. But being driverless gives them an advantage, a cost advantage. That is, once the vehicle is paid for, the incremental cost of rides is almost free. They are electric, and if you have a renewable source of electric energy, there's no driver to pay. And if there's no, that's the main cost of a conventional transportation service, is paying the driver. So if there's no driver, the incremental cost per ride for that vehicle is very, very cheap. So in theory, a community that owned such vehicles or was, somehow paying for the service could afford to, with a fixed budget, they could afford to reach further into the community and provide mobility to places that previously were underserved for economic reasons. So that's the theory, that adopting an automated vehicle, could allow mobility to reach further than it has before. So that's, we're trying to help with this project, the state of Maryland, sort of think that through and think where that would work and how it would work, and estimate the potential benefits from that. This project, I think the reason we got that project was we had done a similar project for the Institute for Assured Autonomy, which is an institute that's located, sort of shared between the Whiting School of Engineering and the Applied Physics Lab. It's a relatively new institute, but they had some grants they were awarding a year and a half ago or so, and we got one of those. And with that grant, we did some modeling in a community in South Baltimore to illustrate how AVs could be relevant to health-related mobility. So in South Baltimore, we did some community outreach, and we learned that access to healthy food was a community concern, and it was very inconvenient because there's just one source of fresh food that's outside of the community and difficult for many people to get to. So we modeled a couple of types of automated vehicle service. One of them is rideshare, which is not driverless, of course, but it's enabled by artificial intelligence. That's how they are able to provide their service. And so we looked at rideshare. We looked at a shuttle loop that could be established, as we described. And we also looked at a different way that automated vehicle would help, and that would be a food delivery service. So an automated driverless food delivery service. And we through our simulations, we compared the efficiencies of all three of these. And if you look at this table in the first two columns, you can see at different levels of service, sort of how a subsidized Lyft ride, so this is rideshare, how a subsidized Lyft ride would affect accessibility. And it you know, at 100%, it doubled the relative accessibility, 1.98. If you look at the next two columns, you see that, you know, the similar effect of a shuttle loop. That was not quite as effective, but would have been maybe more cost effective, because the subsidizing those Lyft rides was quite expensive. But the last two columns show the winner, which was this AV food delivery option. And that, with that option, an automated food delivery service would pick up food from the grocery store and deliver it to convenience stores in the neighborhood that people could walk to. And so that was the most efficient way to use automation to solve that problem. So that project was in turn, that project was an outgrowth in turn of an earlier project that we worked on a couple of years ago with a community development group, the South Baltimore Gateway Project, that we happened to bump into these people actually. They were looking to do an analysis of strategies to improve access to healthy food, medical care, or employment in South Baltimore. And we crossed paths with these people, and we sort of joined them in this project. It wasn't a financial arrangement, but it helped us kind of learn this process. And they were very nice to work with. Our role in working with them was sort of a conventional public health role, I would say, which was, we started with doing epidemiology, and we worked through some modeling and sort of helped them think the process through. We did sort of, what I think is, sort of a conventional public health approach with doing heat maps, comparing access through driving to public transit with, this is access to healthcare, access to fresh food, access to community centers. We also looked at access to employment, and we used, we first took a look at subsidized rideshare, and compared it to public transit. And then we also compared driving and other modes of transportation. We did a simulation of, our partners at the Whiting School helped us with some simulation here, and see if I can show you that this is quite interesting. We picked 50 random locations in our study area, and from the simulation is based on an assumption that at 8 a.m. two people would leave from each of these hypothetical households that we picked, and they would head towards the center of the city, and which was sort of their our proxy for an employment location. And we actually used the School of Public Health as the destination there, since we were conveniently located. But you can see that quite a disparity in the mode of transport chosen. If you look at the people on the blue lines are driving, the people, the green lines are walking trips, and they're walking to transit, and so I'll run this again so you can have a look. You note that the last car arrives at the destination at about the same time that the first transit rider gets there. And the last transit rider at the same time, the last transit rider is just getting on their bus after walking for 25 minutes to the bus stop. And it takes them a further 50 minutes to get to the School of Public Health from South Baltimore. So it's just a few miles, but it took them an hour and 15 minutes to get there. So this is, sort of helped us understand the mobility disparities that that our communities face.
Let me just jump in there and say that this is time that is lost every day for people. It means time away from their families. It means time away from rest and proper sleep, and time away from other things that you do at home, like food preparation. So it's kind of like compounding existing challenges and stresses. So it's for anyone who's ever struggled with a long commute, you can really empathize with this situation. And the name of the software that's used for this is called Sumo, S-U-M-O. And if anyone would like to run this kind of thing, I really recommend you reach out to Professor Tak Igusa in the School of Engineering. He also has an affiliate appointment at the School of Public Health because he's one of those brilliant engineers who understands public health as well. So I'm going to pass it back to Jeff.
Thank you, Jonathan. So that's our work with autonomous vehicles, focusing on sort of access to health determinants, and a lot of it is focusing on the idea of autonomous shuttles being used to provide mobility where it has not previously been economically feasible. So there are other, beyond these technologies, there are other sort of new mobility developments. One of those is smart infrastructure, and that's artificial intelligence sort of built into the system to help vehicles run more smoothly, to control traffic, to control the movement eventually of automated vehicles, to coordinate motion in the city, particularly so that things run more efficiently. It can also sort of coordinate mobility with the delivery of healthcare. For example, providing more predictable patient delivery to health clinics, but it is sort of infrastructure embedded artificial intelligence. So that's an area that we're very interested in. We haven't done any work in this area yet, but it's sort of, I think, on our horizon. Another area where we have been doing a good bit of work is called the safe system area. So this is not a high-tech area. It's actually a bit of the reverse. It's an effort to redesign our current transportation system, our current roadway system specifically, to be more human-centered, and to design a system that is built to serve human needs rather than vice versa. And the design philosophy really has two parts, and one of those parts is that the system should be designed to predict human performance. That is, we have about 40,000 fatalities per year in this country, 40,000 traffic fatalities per year. It's 110 a day or something like that. They are very repetitive. they happen for the same reason. It's the same type of failures. And so the idea is if you've designed a system and you're seeing the same type of failure over and over again, then you need to redesign the system. So if you have a problem where people are in crashes because they are distracted, well, that's because humans get distracted. If it's because they're fatigued, it's because humans get fatigued. If it's because they're impaired by alcohol, well, that's because people drink and it's legal and it's quite popular. And so the idea is if these things are happening over and over again, then we need to design the system so that it doesn't kill people that behave like other humans. The other sort of part of the design philosophy is that crashes will happen. It'll be very difficult to design a system in which crashes don't happen. But there are system attributes which can be adjusted through design so that the energy level in crashes is limited to being within human injury tolerance. So we can design a system that has fewer crashes, and for those that do happen, the energy level is low enough that no one or a few people are actually killed by the crash. So this is a design philosophy that was developed in Sweden and Netherlands in the mid-1990s. They have taken it quite a long way, and they have reduced their fatalities by about half by pursuing this safe system philosophy. The US has not pursued this significantly to date, but we're gathering momentum. And in the past couple of years, there's been a real swelling of interest in this design philosophy in the US. And I think the impetus for this is partly frustration about the plateau that we've been on for so long in the US with road safety. And it's partly about the potential of the safe system to not only improve safety, but improve other things, including equity. So this year was significant in transportation development in the US because of what happened on Monday, the infrastructure bill. Every 6 years, the US enacts a new infrastructure bill, which provides a legislation to support money from Congress flowing through the Department of Transportation in Washington on out to the states to fund roads and road safety work. It's a lot of money. It's typically, in years past, it's been about $40 billion per year. So when those 6-year cycles end, there is always interest in, well, let's redesign the way the money is allocated for the next cycle. Well, this year was one of those, the beginning of one of those cycles. And we, at Johns Hopkins, we were working with the Institute of Transportation Engineers, which is a road builder, and we co-sponsored with the FIA Foundation, by the way, co-sponsored a series of meetings, or consensus meetings, regarding or involving a range of stakeholders about how safe system could be encouraged and promoted and supported by this new federal legislation. So, again, the motivation, the reason we were able to gather interest among stakeholders was because of the frustration and because the promise of safe systems to do more than safety and to contribute to improved equity. The expectation here with regard to equity is really, I think, in two parts. So you can sort of think of it in two parts. The behind the safe system movement is a zero fatality imperative. That is, the safe system philosophy is focused on reducing fatalities to zero. It's sort of looking at the moral imperative of the owners of this road system, of the governments that operate the road system, the moral imperative to not only cut fatalities to an acceptable level, not just reducing them by 2 or 3%, but to reduce them to zero through system redesign. And if it's that zero imperative, zero is zero, and it would require that governments do what it takes to get every part of the population to zero. And that will require more effort for some of the parts of the population, parts that we've left behind with investment. And that's sort of the intrinsic equity aspect of the safe system. Is you can't reach a safe systems goal without equitable treatment of communities. And the other aspect, if that's the intrinsic, the extrinsic aspect of safe systems is, well, as we do this, as we adopt a safe system, we can't do it everywhere at once. We'll have to do it sort of location by location. And if we pick those locations appropriately, we'll pick the locations that have been underserved first. So we'll give priority to those communities who have been left behind. And in that way, we can use the transition from conventional system to a safe system to level the playing field. So that's sort of, you might think of this sort of the intrinsic and extrinsic equity strategy that's inherent with a safe system. So we gathered a broad group of people, transportation, public health, government people, of course, and academia. And we met 5 times, and we produced a document that a 10-page document or so that explained what a safe system is, because this is intended for policymakers that are not very familiar with this design philosophy. And we produced a set of recommendations that covered several areas. One was recommendations for awareness of the safe system and providing resources to get there. Recommendations directed at this equity aspect to provide strong leadership and remove barriers to equitable treatment. And then a set of tools and guidance that will be necessary to help state and local transportation people get there. The examples of these recommendations include resources and demonstrations to illustrate to states and communities how to move towards a safe system. Capacity building for communities that have been underserved and don't have the technical capacity to make such changes, reducing barriers to implementing, such as the requirement for federal match that many underserved communities have trouble meeting, and producing guidance documents and tools. The road building community works by institutions, and they rely on manuals and guidance, and so we need to change those manuals and guidance. So we provided recommendations in that direction. We pointed these recommendations at the Congress for the new transportation bill and to the Biden administration, to the US Department of Transportation specifically, so that they could interpret this new legislation and provide programs for states and communities. And finally, Monday was a big day. The infrastructure bill was signed, and it really is a big deal for road safety. This is the first time we had some success. We had some influence with the Congress with this approach, and it's the first time that Congress has endorsed the safe system approach. And there are really huge new resources for states and communities. There's a $6 billion Safe Streets and Roads for All program that is pointed in this direction and encourages innovative programs at the community level. So I think we'll stop there and hope that maybe you'll have some comment or suggestions for us. This is kind of an overview of what we're doing, and I think we sort of expressed our rationale for pursuing this direction. We're hoping that you might have some suggestions for us to about the relevance of our approach, or strategies to leverage this approach for greatest effect to improve health equity.
Well, first, I'll say thank you to both of you for that very enlightening presentation. There's so many issues, equity issues that are sort of embedded in this topic, ranging all the way from, people with physical disabilities, other kinds of disabilities, all the way to people living in food deserts and, in segregated, neighborhoods, things like that. So thank you, for your leadership in this space. I'm going to make sure that there were a lot of people asking a lot of interesting questions in here. So talking about things that you might have to deal with as you study these issues and some of the pushback you might be getting from people who are in the field. So I want to give you the opportunity to respond to some of those. I know you did respond to some of the issues in here. And then maybe if you can frame, for us, any specific questions you have that we can answer related to the work, or if there are others who have specific recommendations to offer right now, I welcome that as well. So yeah, people talked a lot about for example, like the one issue I just brought up about the pushback that you might be getting from people who are in the field already on these issues. There were some comments related to enhancing access to healthcare. The other people seem to have dropped off. They were telling us that they were dropping off. So I was just looking at the comments. Yeah.
I think this issue of pushback that you mentioned is really interesting, because it's not what I was expecting, frankly, but has turned out to be maybe our central problem right now, our central barrier to move forward. And as I talked to our European colleagues, it was theirs as well. It was the same in Sweden, and the reason is this institutionalization. And I've worked with government people a long time, and they're really good people. Their motivations are same as ours, and they really want to do the right thing. But their rewards and their incentives are sort of aligned with doing things in the conventional way. And so if you talk to them about changing their role, then they kind of, their mind goes to, well, I can't do that. I wouldn't get paid for that. That's, I need to follow these policies, and the policies are written differently. And so there's tremendous sort of institutional inertia that needs to be overcome. And that's going to take a lot of work. It's taking a lot of our attention right now.
Could I just ask to what extent you have engaged with the communities and the groups of people that are affected by this problem, so to work in partnership with them in advocating for some of the changes, or some of the more focused attention to the problems you're uncovering?
Yeah, obviously not enough. I'll let Jonathan comment, but we were able to do some of that in South Baltimore in our pilot work. We were able to do that, and that's a big part of the project we're doing in Maryland with connected and automated vehicles. So we'll be doing that, but I wouldn't say that we're good at it. We sort of do it by the seat of our pants. And I think that there probably is a science to doing community engagement, and we'd really like to learn about that. So if any of you have experience or skills in that area, we'd love to talk to you.
Yeah, so I think that's a lot of what we do. So, we're very much interested in speaking with you more about that, and having it be a process that is woven into all the work you do, and that is, not necessarily focused on a specific project, but it's something that you can build upon, so that that engagement will be there consistently, because I think that's what's needed. Many people who have experienced disenfranchisement or, social marginalization are frustrated with the fact that they are approached by experts for a specific problem, but not that when that particular issue is dealt with, then they sort of feel like nobody's there to listen to them anymore. Right.
I can appreciate that, and I, the interactions we've had, have been extremely positive. I sort of, at least from my point of view, I went into these things, a little bit timid, because I'm nervous about these issues. And, I'm aware of the disappointments that the community has had previously. But I've been pleased so far that the people have been so positive and, I guess so trusting.
Yeah, you're paying attention to a problem that, for many people, nobody has paid attention to for so long, that I imagine they're happy that somebody is noticing and caring about these issues. One strategy you might consider is establishing a formal community advisory board.
Yeah, that would be a good idea.
Mm-hmm.
But we've struggled with, from our perspective, how do you know when you've sort of gotten, sort of the authentic community voice, and, when you kind of make inroads into the community, at least we seem to touch down in a few places, and then we're not really sure. Those people have been great, but we're not sure if they represent others or if they are sort of a special interest in the community. It's hard for us to tell. So that's where I suspect that people who are good at this have a way of, sort of validating their input in some way.
Yeah, well, I think there's no way to know for sure whether you have everyone at the table, but you can certainly go out of your way to look for diverse experiences or perspectives. And then you can also rely on people that you do engage with and ask them who else should be here that we aren't thinking about.
Yeah.
So I think there is a comment in the chat that I want to raise for you from Allison Trainer, who's one of our new research program managers. Allison says, I'd be curious about the input from the community and general population about AVs. Unfortunately, a lot of what makes headlines with AVs are clickbait related to imperfections, crashes, et cetera, that I think overshadows the positive content, that you all shared. So
Yeah.
that's one
Jonathan,
comment.
do you want to comment on that?
Yeah, thank you, Alison. It's a great point. Yeah, I think about this a lot because my work actually began in the area of teen driver safety. And I'm currently teaching a young person how to drive. And the fact, like really, I mean, I want us to just kind of pretend we're aliens for a second and we're coming to visit planet Earth for the very first time. And the fact that we put 16-year-olds in charge of 1 ton of steel that can go 100 miles an hour, it makes no sense. It makes 0 sense. And I really think that if aliens were to come here one day and say, for example, see that everyone's actually driving around in robot vehicles rather than human-driven vehicles, it would make a lot more sense. I think 40,000 people roughly are killed every year on this country's roads. And, a lot of them are not at fault. And 1.2 million people are killed globally by crashes. We kind of have come to accept this as the cost of doing business. The cost of mobility is 1.2 million lives lost per year, 40,000 in this country. It's really depressing that, COVID came, we shut our country down and we shut the world down. I'm not trying to make kind of, parallels here that are unreasonable, but it's funny how now that society is reopening, we're kind of like accepting, oh no, COVID's here to stay. We're going to accept some deaths. We're going to accept. Well, this has been the case with motor vehicles for a very long time. And I think the fact that we could, now, autonomous vehicles won't be perfect, but they'll probably be better than most teenagers, and they'll probably be better than most drunk drivers. Impaired driving, it takes 10,000 lives a year. So yes, Alison, very astute point. People have a kind of an irrational kind of fear of kind of crashes from autonomous vehicles for very good reason. You're not in control. And, being killed or being, at risk by something you can't control is a really scary feeling, but thinking that you have control is much more reassuring. But I think it's going to take kind of a watershed or a real change in thinking. It's going to take also some work on the part of public policy and the industry itself to demonstrate safety and public benefit. And I think this is where we want to position ourselves in the School of Public Health as saying, let's demonstrate the safety and the public benefit. And in fact, let's weave social benefit into autonomous vehicles from day one, instead of it being an afterthought. And I have to say that, I've got the good fortune to work with Jeff. He's really at the forefront of this. He chairs the Academic Advisory Group for the Partners for Autonomous Vehicles Education, which is a national group. And we're really kind of like, if you like, we're kind of testing a really big hypothesis that we can pull this off. And we need partners to do this. And we feel like the community who's gathered here today are natural partners for us in this work.
Yeah, there's sort of, I think, an important, perspective to remember, which is, this is an industry that we're talking about, that they're a profit-making industry. Silicon Valley is investing billions of dollars in products that we haven't asked for, they're just making them, and they're making them with the expectation that we'll use them. Well, we can set the bar. That's sort of our approach here is, we can set the bar on how they perform, and we can ask that they provide social relevant service first. And that will let you into our community, but we want you to help us. We want you to help people that need help before you provide a service, yet another service for people that can afford it. So I think we have that opportunity.
No, I appreciate that very much, especially given where I'm sitting right now on the President's Council of Advisors for Science and Technology, where one of our main concerns is that, advances in technology are not necessarily going to advance the health and well-being of everyone if we aren't mindful and proactive in making sure that it is. So
yeah, that's right.
That. Well, I see one more comment from Raquel Hernandez saying the use of community health needs assessments can help you identify who is in your catchment area, who might be a good partner or perspective to include in your work. And of course, you have a lot of data too about people's travel patterns and who might be most at need for some of the services that you're looking at.
That sounds good. I'd like to learn more about that.
Yeah. Let's see. Natalie Wiggins from Urban Health Institute saying that she used to believe that community associations could be such a valuable resource, but recently realized that people are people in the most profound way, and they always have their own personal vested interests, even when they say they represent the community. So yeah, we also have to keep that in mind too, that people are often representing their own interests, and that's okay, as long as maybe there are other people who have similar interests to theirs. So, are there any other questions or comments? We are happy to have you and happy to continue to engage with you in this work and to support you in any way we can, and to think about some of these issues in our own work and the relevance of these issues. I see Nancy has her hand raised, or?
Oh no, I'm just clapping. It was very.
I just want to thank you, particularly Dr. Cooper, for the invitation. We've really appreciated the opportunity to share some of this work. The thing I love about transportation is that everyone can relate to it. It's something that we all have a very deeply and personal experience with. And we know how much of a hassle it is if you don't have transportation, and how much energy and time can go into getting places. So, we're very pleased to connect with all of you today. If you have, we're in the Department of Health Policy and Management. Feel free to reach out to us, and I'll drop our emails in the chat. And it's just such a delight to have the chance to speak with you today.
Thank you for coming. It was a pleasure to have you.
Thank you very much. It was a great opportunity for us.
All right, well, we're going to wrap up this month's Health Equity Jam session, thanking our speakers for a very illustrative session today, and everyone else who participated. And just to remind you that our next month's jam session is actually going to be a little bit early. It's going to be on December the 1st, because we want to, miss out on all the holiday. We don't want to conflict with a lot of the other holiday activities. So we look forward to seeing you in a few weeks, and wish everyone a happy and safe Thanksgiving holiday. Thank you for joining us. Bye-bye.